I'm Scott Podolsky. I helped to organize our Department of Global Health and Social Medicine seminar series, and our department is thrilled to co-host multiple seminars this fall devoted to the health of Indigenous peoples. And for this, we're grateful for the wisdom and input of my colleague, Joe Gahn. I'll get to introduce Professor Gahn himself, and he'll have the honor of introducing today's speaker, Dr. Melissa Walls. Joseph Gahn is Professor of Global Health and Social Medicine in our department and Professor of Anthropology in the Faculty of Arts and Sciences in Cambridge. He's collaborated for over 25 years with American Indian and other Indigenous communities to rethink community-based mental health services and to harness traditional cultures and spirituality for advancing Indigenous well-being. He's an enrolled member of the Ani Rovan Tribal Nation of Montana, and among many other roles is the director of the Harvard University Native American Program, with whom we're co-hosting today's talk, and an elected member of the National Academy of Medicine. So with that, I'll hand this over to Dr. Gahn.
Thank you, Professor Podolsky. I really appreciate your warm introductions to all of our seminars this season. And I just want to reiterate that I'm so pleased that we've come together to collaborate on this Indigenous Health and Wellbeing Colloquium series, jointly put together by the Harvard University Native American Program and by the Department of Global Health and Social Medicine at Harvard Medical School. Let me start today with an acknowledgement of Indigenous land and people that we typically do at HUNAP. Harvard University is located on the traditional and ancestral land of the Massachusetts, the original inhabitants of what is now known as Boston and Cambridge. We pay respect to the people of the Massachusetts tribe, past and present, and honor the land itself, which remains sacred to the Massachusetts people. And we're so pleased to have been able to enter into a partnership and collaboration with representatives from the Massachusetts tribe at Ponkapog to develop this acknowledgement. So these are the words that they prefer that we say at such openings. I'm really delighted today to introduce our speaker for this next installment of our HUNAP colloquium series. Dr. Melissa Walls, PhD, is an Anishinaabe social scientist who works in collaboration with Indigenous communities in the United States and Canada on health equity research and the development of culturally relevant public health programs. Dr. Walls is an associate professor of American Health at the Johns Hopkins Bloomberg School of Public Health and director of the Great Lakes Hub of the Johns Hopkins University Center for American Indian Health. Dr. Walls is a member of the longstanding research team that includes Anishinaabe community members and academic researchers working together to understand and address the social, historical, and contemporary determinants of unequal health outcomes. And Melissa, we're so delighted that you joined us today. As I've said, the title of your talk is Indigenous Mental Health and Wellbeing over the Early Life Course. And you are leading this really impressive study that is longitudinal. It's one of the few in Indian country that's ever been attempted at this scale. So we're very excited to hear what you have to share with us today. So the floor is yours. Take it away.
I will do that. Thank you so much, Joe. I'm going to start my timer. I want to acknowledge all of these attendees. I'm scrolling through the name list. I can do that as a panelist, and I see a lot of friendly, not faces, but names, because I can't see your faces. So I just want to acknowledge you all for showing up. Some of you I've met and known, some of you I've cited a lot, and so it's great to see that you're showing up and spending this hour-ish plus a little more with us. And Dr. Sparrow, nice to see you too. I see that you put something in the chat. So I'll go ahead and get started with the actual formal presentation. As Dr. Gahn mentioned, I'm really excited to get to share information with you all about a longitudinal study our team is engaged in. And so without further ado, I want to say hello from Duluth. So greetings from traditional Anishinaabe territory, waterways, and lands. Now, this was a few months ago. There is snow on the ground today, just a little bit. And I noticed Dr. Jordan Lewis has joined us. He's also in these territories. These Anishinaabe waterways were homelands to Dakota people before us and other tribal peoples in this area. If you haven't ever been, come visit us in Duluth. It's a beautiful little spot on the shores of Lake Superior. And this picture is taken right outside the front of our office here in Duluth. So I work for Johns Hopkins University. I'm part of this center that you can see on the screen, which was founded in 1991, in part to do work around primarily infectious diseases. And I've been saying for the past couple of years, just before this pandemic hit, I think our center has really grappled with, do we still need to do infectious disease work? And then COVID-19 came, and I can't tell you how grateful I am to be able to work in partnership with Native communities and with this center with a long-standing history of knowing how to tackle infectious diseases. It's been really, fortuitous to be able to come to the center just before the pandemic. And so we joined the center as a team in 2019. So most of my time with Johns Hopkins University has been during a global pandemic. As I mentioned, we're here in Duluth, and we work primarily with Anishinaabe or Ojibwe communities. As Joe mentioned, I am Bois Forte and Couchiching First Nation Anishinaabe myself, and so grew up way up on that Canadian border in a little town called International Falls, which is known as the icebox of the nation. And I'm so pleased to be able to get to share some of our team's work with all of you today. And just wanted to share this picture. This is the grand opening of this little hub of the center. And we welcome you all to come visit us here on the shores of Lake Superior in the winter or the summer, anytime you'd like. So to get us started, you all, if you're at this talk, if you're at this presentation, you probably know that our communities, the Indigenous communities in America, really have some of the most extreme health inequities that you could observe anywhere in the globe. And, you know, we have the highest premature mortality rate in the United States. That's the greatest indicator of loss, really. Fewer years of life on this planet, right? Some of the causes of this premature mortality are listed on the slide here, and of course they overlap, of course they interplay with mental health. So for example, our team studies type 2 diabetes quite a bit as a chronic disease. We find, as have others, that chronic diseases are both impacted by and influenced and impact, mental health. So for example, if you have both depression and diabetes, you're more likely to have complications. You're actually more likely to have premature mortality. You're more likely to die to these co-occurring conditions than if you had just one or the other. So mental health, really permeates all of these leading causes of death for Indigenous communities, which is what I've got listed on the screen here. And of course, suicide, probably a very acute indicator of mental distress. I put this on the slide as well as some more recent data to just illustrate what we're grappling with when we talk about health inequities in Indigenous communities. So here in the United States, all of these bars, different colored bars, represent premature deaths, right? And so these are projections. So if you look at the x-axis, we started in 1990, we go out to 2030. These data are showing us where we expect people to be passing, what age they will die into the future, right? And so the good news, if you look at this as an epidemiologist, is, oh, look, most groups, it seems to be that premature death, so dying early, is going down. That's good, right? That means we're living longer. But the green bar represents American Indian and Alaska Native communities. And what you can see, it may be difficult to see, but for women, we are seeing projections of increases in premature death at the highest rates of any group, racial or ethnic or any gender, on these line graphs. Native men, it's also going up at a slightly lesser pace, but what this should tell you is when all groups in America, with the slight exception of white women, where you can see a 0.15 increase, projected increase, our community members are dying younger. And the data continue to tell this story. And with the impacts of COVID-19, it's only getting worse. And so what is to be done about this? What is it that we can collectively do? And in my role as a researcher, what is the role of research in trying to stop this? And how can we use research as a tool to really take action? So that's really the mission of our team. And we also want to highlight what so many of you do in your work, which is tell the story that this was not always the case for us, right? These inequities are deeply rooted in colonization and marginalization. Now, I know that this lecture series has had prior speakers, including just in the past year, talking about historical trauma at length. I won't be going into length or into detail on those topics. I'll mention some measures and some data around this, but we have to remember that this is a social response to social determinants that are deeply rooted in history. This is not always the way it has been. And we have data, right? If we look at public health data over the years, we know that this is true. And so remember that narrative, right? This is not because of something about being Indigenous. It's in the face of being Indigenous, I think, that we experience these inequities. So what are we going to talk about today? What's our focus? Well, I want to use a case study from the Healing Pathways Project, which is the study that Dr. Gahn mentioned at the opening. And I am really honored that we get to spend a good chunk of time just really highlighting the history of this project, which began well before I was doing research, but continues today, because I think this particular study offers a lot of tools, a lot of data, and a lot of empirical information to leverage what I just said on the prior slides, right? That our communities haven't always had to deal with these inequities, and that the drivers of these inequities are social in nature and therefore changeable. They're malleable. We can do something about them. So that's the goal today, is to share, just some findings with you, and then have a little Q&A time and conversation time. I am just one member of the Healing Pathways team. I currently serve as the principal investigator, but really this team is built up of a bunch of principal investigators. In truth, we collaborate. These are some of the Community Research Council members and interviewers, project coordinators, and team members from the project. I'm going to share a few pictures of them because they are so amazing. Here's another group of all of us now. The red hats came before what now people wear for red hats, which is Trump. So I want you to know this is not a political statement. These are Healing Pathways hats. Who knew red hats would become something, but they have little Healing Pathways logos on them. Here's another photo of us doing an honoring event for our interviewing team at the end of some very lengthy interviews. So I do want to let the team members say a few words, and I'm going to give this a shot, and I'll just ask one of my co-hosts here to tell me if for some reason this doesn't work. It should just be very quick. And here we go. Give it a shot.
Bonjour.
Bonjour.
Bonjour. Bonjour.
Bonjour. Welcome to the Healing Pathways YouTube channel. We are so excited for you to be here.
Healing Pathways is a collaborative research project.
It includes 8 reservations and reserves alongside university team members.
Since 2002, we have been collecting survey information from participants to learn about Indigenous youth and young adult development.
Healing Pathways participants have shared their stories with us since they were 11 years old for a period of nearly 20 years.
For this, we are so grateful to all of our participants. Miigwech.
Check back here for Healing Pathways updates and findings.
And like and subscribe so you can get all of our notifications as we post videos.
Kiche miigwech.
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 Miigwech. Miigwech.
Miigwech.
Okay, so, much more entertaining than listening to me tell the same story, although I'll now go into more detail. So those were some of our team members who decided to create a YouTube channel, which is something that was a byproduct of this large project. And I'll briefly mention more about the YouTube channel in a bit, but you can feel free to go to YouTube. And as Whitney said, like and subscribe. I think we have a grand total of like 60 subscribers. So we are definitely not influencers yet. But maybe you'll change that with the talk today. So more about this project. So this is a CBPR, community-based participatory research study. It involves 8 reservation and reserve communities, 4 in the US and 4 in Canada. And all of these communities represent a singular cultural group with very diverse histories, as many Indigenous communities have. It represents 20 years of partnership, as you heard our colleagues say in the YouTube video. And our work is not just epidemiological or basic research, but also prevention work. And the heart of the study is the panel study design. So initially back in 2002, we enrolled what are called target adolescents. So we call them now target participants because they've grown up. They're no longer adolescents or youth. But these target adolescents in 2002 were sampled from tribal enrollment records. And the criteria for them to enroll in the study was that they had to live on or within 50 miles of the reservations or reserves that we are working with. At baseline, back in 2002, these guys were 10 to 12 years old. So on average, 11 years of age. And they were interviewed every year for 8 years. And then we've recently done 3 more years of interviewing. Back in those original 8 years, we interviewed not just the target participants, so the adolescents, but also at least one of their adult caregivers. So 2 generations of data, which is really a compelling point. And we have at least data from 1 caregiver, in some cases 2. So there's roughly 730 target participants at baseline, and about 1,000 of their caregivers participated throughout the study. So the data for this project are collected using survey methods. So it is a survey-based research project, and we use personal interviewing techniques. So all of the interviewers, some of them were in the video you just saw, are members, community members, or enrolled members of the communities with which we work. And they did a variety of techniques. So they use computer-assisted personal interviewing, paper and pencil interviews, and we had diagnostic interviews in some of the years as well. And I'll talk more about what I mean by this word diagnostic interviews in a second. People often ask me, especially outside of Indigenous contexts, well, what's your retention rate for this study? So back in 2002, the original enrollment rate was around 80%. So about coming up on 80% of the participants who were invited actually enrolled in the study. A couple of years later, we had hung on to about 91% of the participants. And you can see the number kind of dips down in 2010, which was the final year of that 8-year initial study. We had about 82% of the initial participants. If you fast forward to the most recent 3 years of data collection we just completed, now you have to remember these participants now, as of right now, while we sit here today talking, they're about 31 years of age. So now they're entering, well, they're young adults, right? Between 2016 and 2021, we did 3 years of data collection. And when we counted to see how many of the original baseline participants we got at least once during those 3 years, we hit 84%, which is really wonderful. I showed the average there because, as you might imagine, in 2021, it was tough. So we were doing interviews from 2020 to 2021 during a pandemic. The response rate was quite low that year. The retention rate, which we would expect, and we did not push. It is what it is. That's kind of the lesson of the day for research right now. I do want to briefly mention these collaborative strategies. So one commitment that we really have and that we are working hard to do even better on is making sure that this wealth of data is actually used by the communities from which it is collected. So there are a lot of things on the front end before you even write a grant application that really, in my opinion, should be done to encourage partnerships, co-creation, and really get approval to do work on tribal lands. So in our case, this comes in the form of tribal resolutions that accompany grant applications, indicating that tribal leaders and tribal governments have exercised a sovereign decision to allow us to do this work within their boundaries and territories. The formal structure that our team has created for co-creation is called Community Research Councils, CRCs. So I may, throughout the rest of the presentation here, talk about CRCs. These are my co-investigators. We work together throughout the entire research process, everything from what are we going to ask in the surveys to what are the first papers we should write to why not create a YouTube channel? Why not create a Facebook page? We have all of this information out there. At the end of the presentation, I'll share a link to our webpage. If you go there, you can find direct links to all of the published papers, YouTube videos, infographics, and creative ways of disseminating these data beyond the typical academic talk like I'm doing today, or academic publications, although those are also on the page. And of course, I can talk more about community-based co-creation later if there are questions about it. So let's get into the science of the study. So from the perspective of our team, we really wanted to tap into multiple spheres of influence on the original target participants. So if you consider the adolescent, they are the target participant. We know that in adolescence, peers and schools really matter, as does family. And we also tapped into measures to assess community contexts. This word enculturation, that's a big word, enculturation. What does it mean? It means so much. It means everything in our study from cultural engagement, and by culture here, I mean traditional Indigenous cultural ways, however you define that. And there's more to come on that topic in a second. To innovative measures of cultural efficacy, I'll show you some data on that, to language use, all sorts of things. So enculturation is really this process of adopting or being embedded within your traditional culture in the case of this study. We also consider geography. We have Canada, we have US. These are unique political contexts, but also unique geographic contexts. Some of the Canadian reserves, super duper remote, at least by my standards, and I live in Duluth, Minnesota. Although I will say that one of our collaborating teams lives the furthest north. They say, oh, we're not remote. You don't have to take a bush plane to get to us. You can drive to us. So very relative, as you all know. And then finally, history. I opened earlier by talking about historical trauma briefly, but history matters for everyone. We know this from life course theories and developmental theories. And we really explicitly want to pay attention to the reach and the impact of history in the context of Indigenous adolescent development in this study. So I will show you just some brief findings on what we're learning in that regard. So the focus today is mental health, right? Mental health and well-being. What are some of the key findings that Healing Pathways has been providing? Well, I will share with you some prevalence or frequency data today. I also want to show some correlates and or predictors if you want to use a nomothetic causation approach because of the longitudinal nature of our data. Briefly, I'll mention some complications around how do we even measure these things like mental health and especially culture and ethical issues that intersect this. And then just sort of end with hopefully something positive, a little positive surprise that came out of the study. All right, so first, diagnostic measures. What do I mean when I say diagnostic measures? Well, in the context of mental health, I am talking about DSM criteria for mental disorders. So if you're a psychologist, a physician, a psychiatrist, a social worker, many of you use the DSM to generate or read criteria for diagnoses. Well, in the research world, there are structured diagnostic interview tools that we can use to approximate what a clinician might come to through interviews. Now, these are rigorous interviews. These are burdensome interviews, and we've been doing them quite frequently in the Healing Pathways study. They do require the use of computer-assisted personal interviewing, so you need a tablet or a computer. They do require often special training for the investigative team and the data collection team. I won't go into great detail here, but this is one of the gems of the Healing Pathways study, the fact that we have diagnostic measures. So the tools we've used in waves 1 through 8 now I'm just talking about the target participants, the youth, but we've also assessed their caregivers on these measures. But for the kids, we use the diagnostic interview schedule for children revised in waves 1 through 8. And then because they're no longer kids in wave 9, by wave 9, by the way, they're 26 years old. We had a big gap in between the two studies, the two waves of, or the two, phases of the study. We use the University of Michigan Composite International Diagnostic Interview. So this City is what was used in the National Comorbidity Surveys. So I will show you what we learned using these measures. Now, we had to do some algorithm checks and comparisons to make sure that we're comparing apples to apples with these different criteria. And so one thing that I will say is some of the early Healing Pathways papers on diagnostic rates include more detailed things than I'm going to share with you today because we had to exclude some of the childhood disorders for ease of presentation. So first off, let's talk about our lifetime rates. So when I say lifetime rates, I mean over the course of one's entire life, did they ever meet criteria for these various substance use disorders? Now, first, some acronyms. SUD, substance use disorder, GAD, anxiety, MDD, depression, ADHD, attention deficit hyperactivity, that's one most people know. And then probably the bolded is most interesting to a lot of people, which is, did a person meet criteria for any one disorder? Or did person meet criteria for at least 2? Then I have, before we get into the numbers, and I know my eye jumps to the numbers right away, but I want to give you this background information. A bullet for cumulative and a bullet for retrospective. So most studies in the world, because of money, because of time, are what we call cross-sectional, one snapshot in time. With a cross-sectional survey, for example, how do I learn about your lifetime rate of disorder? Well, I have to rely on what we call retrospective or looking back accounts. So I might do like a little life history interview, and these interviews for the diagnostic assessments do have very structured ways and empirically supported ways of diving back into people's lives. So these retrospective accounts, despite all of the tricks and techniques we use to try to get accuracy, we are human. We don't always remember everything accurately, right? We know this. If you're in the mental health field, if you're a psychologist, you know this. We don't always recall correctly or accurately. So retrospective accounts of disorder. So when in these interviews, people are asked things like, was there ever a period in your life where you felt very down for a period of X number of days? You know how, if you're in mental health, you know how these diagnostic things work. Do I remember that? I'm not sure, right? So these retrospective accounts tend to underestimate the true rate of disorder in any given population, but they're often what people have because of, like I said, of time and money. Well, in Healing Pathways, we asked about diagnoses at multiple waves, 1, 4, 6, 8, 9. And so we have multiple times at which we've asked them these questions. And so we were able to generate what's called a cumulative rate of lifetime disorders. And that is by taking the retrospective at wave 9, for example, but also adding in anybody who was missed at wave 9 who had met criteria at one of the prior waves, okay? So that was a long-winded explanation, but I wanted to put it out here. Why am I showing these things? I'll show, the punchline will come in a couple of slides. So first thing I notice, if I'm looking at this slide, well, probably the red font, because that's what I wanted your eyes to see. But really, if you look at any of the specific disorder types, so substance use, anxiety, depression, ADHD, really the substance use disorders are much, much higher in prevalence than any of the other disorders, right? By quite a lot. And so the cumulative rate of meeting criteria for any substance use disorder, so this could be any alcohol or drug use disorder of any type, is coming up on 70% at wave 9. So at wave 9, these participants are on average 26 years of age. So the young adults in Healing Pathways, almost all of them, if we're using, well, let's say 70%, met criteria for a substance use disorder at some point in their life on these cumulative measures. Anxiety rates are actually sort of low. Same with depression, especially compared to general population studies, and I'll talk more about that in a moment. ADHD is really interesting to me because the origins of Healing Pathways were in part because of ADHD. There were community members, including my own uncle, who really felt that kids were being overdiagnosed with this condition, ADHD, and then medicated. And what our data show is relatively low rates, especially compared to the amount of medication that was being prescribed, of at least point estimates, so within a given time frame of ADHD. I'll share more about that in a second. And then finally, any one disorder, coming up on 80% met criteria for any one of these disorders at some point in their life. And comorbidity is, did you meet criteria for at least 2 or more disorders? And this usually results in significant impairment, significant social challenges or other life challenges. And we found that over half of the Healing Pathways young adults met criteria for comorbid mental health disorders at wave 9 of the study, so at age of 26 years. So these are just numbers, right? What do we do with numbers? Well, there's more we can do with actually the diagnostic interviews. So what you see on this screen is past year. So the prior screen was entire life. This is past year. So a couple of things to notice. First and foremost, transparency. The y-axis for each of these boxes is different so that you can see patterns. So it goes from 0 to 30 for the substance use disorders, but only 0 to 7 for anxiety. Notice that when you're reading these, but you can also look at the published paper that where this is, it'll be linked to at the final slide if you want to see actual numbers. What I want you to see is patterns. So if we look, for example, the green bar is female, or the solid bar is female, and the dashed bar is male, we can see that at wave 1 of the study, when our participants were about 11 years of age, rates of substance use disorder almost non-existent. By wave 4, when they're about 14, they're up in the quarter of kids meeting criteria. Wave 6, we see female rates of substance use disorder peaking and then going down afterwards. Now, again, this is past year estimates. So it's sort of a incidence in the past year, which tells you where are peak periods of risk. So if I'm looking at this, I'm thinking, okay, I need to intervene early if I want to prevent substance use disorders, probably when kids are about 10 years of age, which is what our team does. We create prevention tools that start in late childhood. And I also want to notice that, wow, the girls are really peaking here in their teen years. And we know there's a lot of stuff that comes with teen years that's already difficult. What can we do to create services or diversion? What can we do to help, right? And that girls actually have higher rates of substance use disorders than boys until young adulthood, when their rates start to go down. Both of the internalizing anxiety and depression rates kind of pop up into early adolescence, then go back down, and then they're coming back up again in young adulthood at wave 9. So remember, at wave 9, the participants are about 26 years of age. And ADHD rates, these point estimates, again, especially for the girls, are actually quite low throughout the study. And by age 16, almost virtually non-existent. So these point estimates, again, tell us great information about periods of risk within any given year. Now, same thing, but this time I'm showing you any disorder and comorbidity. So again, it can sort of tell us where are things really escalating? Again, it's in this early adolescent from age 11 to 14. This is when rates of any disorder are really popping up, similar with comorbidity. But we also see at wave 9, when we're in young adulthood, participants in the study, again, are starting to show an upward trajectory and meeting criteria, for any disorder or for comorbid conditions. So I do want to share this with you. First, what if I only had retrospective data? If I only had a single time point and looked backwards, and at this particular bar chart, I'm talking about wave 9 data from Healing Pathways. Well, as I had shown you before, I would tell you a story where, a good chunk of Healing Pathways participants are meeting criteria for any mental disorder that we assessed. And it's kind of on par with a national sample of American Indians, and a little bit higher than the SuperFIP study, which is another epidemiological mental health study of Indigenous peoples, and quite a bit higher than the National Comorbidity Survey, which is a nationally representative study. So the story I would tell you is rates of retrospective lifetime disorders in Healing Pathways participants are higher than national studies and higher than some Indigenous specific studies, but kind of on par with a national sample. But I don't have retrospective data only. I have prospective data as well, cumulative reports. And when I plot the same sort of thing and compare our findings to other cumulative studies, so longitudinal studies, we're actually on par with or lower than what people see in other studies. This is a really compelling finding to me. What stories are we telling with our data? What are the limits of cross-sectional designs, and how does that relate to everything that we're putting out there? So other take-home messages, what you don't see in those substance use disorders at wave 9 is that a big chunk of what accounted for the jump in disorders is actually related to what a lot of you know about right now, which is the opioid epidemic. So in the early waves of the study, we saw very low rates of, for example, opioid use disorder or methamphetamine or even prescription painkillers. But at wave 9, which again occurred about 2017, big jump, and it was all accounted for, or mostly accounted for, by painkillers, stimulants, and opioids. As I just mentioned, if we only looked at cumulative data, we would see similar or lower rates of overall psychiatric disorders in this sample compared to other studies like this one. However, if we only use the retrospective data, we would tell the opposite story. And one thing that's sort of fascinating to me, and it's hard because this is a single cultural group. So that's another issue with mental health epidemiology with Indigenous communities, right? Like we need within culture studies, but we also need to know kind of the bigger picture. What we see in this within culture study are declines in the rates of substance use disorder during periods of what would be heightened risk identified in nationally representative samples, that is early adulthood. We see some slight declines happening for these substance use disorders despite very early onset. Now, does that mean that early onset substance use disorders is inconsequential? No. We know that there are consequences beyond just other disorders popping up. But also compelling is that in our study, substance use disorders were the highest, like the modal category for diagnostic criteria, whereas internalizing disorders like depression and anxiety, that's what you see in general population samples. So this to me is telling a story of culturally specific epidemiology, perhaps. But again, how does this relate to other Indigenous contexts? We don't know for sure. There's some other studies out there, but not a lot. Briefly, I want to mention this idea of enduring mental health, and then I'll spend a few minutes on non-diagnostic measures, and then we'll move into Q&A time. So enduring mental health is this idea that people have published on that you never meet criteria in your life for a mental disorder. Well, actually meeting criteria for a mental disorder is normative in the United States and in most countries. Most of us do meet criteria at some point in our lives, but based on some imputed models, so accounting for any attrition, about 12% of our sample would never meet criteria for a disorder. This compares to 17% in the Dunedin longitudinal study in New Zealand. So a small chunk of people who never meet criteria, again, I don't know that that's like an idealized pedestal to be on because the demands of life are such that we probably are going to meet criteria at some point. But what are the predictors of people who are in this situation? Well, they tended to not experience adverse childhood experiences or fewer of them. They also tended to come from families where their ancestors did not go through residential or boarding schools. So they maybe weren't feeling that experience of historical trauma, although all Indigenous peoples have a collective experience with it. Their family hadn't had boarding school experience. They didn't have early onset disorders, and they didn't have early onset substance use. And then that small chunk of people also tended to have better odds of completing a college degree. They made more money. They had higher family satisfaction scores. They scored better on this measure of flourishing mental health. And they were actually more engaged with their community and scored higher on a communal mastery measure. So this idea of enduring mental health is one that, again, isn't normative, but it's interesting to see that there's some predictive validity with these diagnostic measures. So I want to spend the rest of the time then talking about non-diagnostic, DX's diagnostic measures. So these are not using those structured interviews. They're using screeners or other measures like the PHQ or the GAD-7. So what we've learned, if I had to put it in a nutshell for you from Healing Pathways data, is that story that so many people tell: stress and trauma harms our mental health. And Healing Pathways shows that stress and trauma like discrimination, perceptions of cultural loss due to historical trauma, other indicators of historical trauma, having adversity in your childhood, experiencing all of these things on the slide tend to be predictive or correlated with worse mental health. Probably not a surprise, but some of these things are not often measured in general studies. There's a lot going on this slide, I realize, but I do want to share with you that one of the measures Healing Pathways was probably most known for early on is the historical loss scale. And this is a measure that elders who were early participants in or early collaborators on the project wanted to assess the sense of loss associated with colonization. So they came up with items through focus groups like, how often do you think about the loss of our land, the loss of our language, the loss of our family because of boarding or residential schools? And you can see that if we look at the daily or more than daily categories, about 20% of the Healing Pathways kids or adolescents said they think of loss of land at least daily or more than once daily. And 12% of the adults said this. Now, Look over at the never column. 35% of kids said, I never think about that. And 16.5% of adults never. So if people are perceiving these cultural losses, it tends to correlate with worse mental health outcomes in this sample. It gets complicated. I will kind of end this whole spiel with the complications. And I will also share that a Maori scholar said to me one day, Melissa, why are you calling it cultural loss? Did you lose it like you lose your car keys? And I was so embarrassed. Now, I didn't name the measure, so I can't take credit for it, but I will say that we have piloted alternative language like the taking of our land, attacks on our spiritual ways. When we use alternative language and compare it to this original language, the frequency responses seem to be pretty similar, and the predictive validity is about the same. So the difference, though, of course, is the narrative we're putting out there. Our land was not lost, it was stolen, right? And so there's a social justice component to research that I just felt like I should mention. Now, what about culturally specific stressors in the context of stressors that people measure in all kinds of studies, even outside of Indigenous contexts? These are just a series of regression models. Basically, what this is doing is throwing a bunch of variables together to predict psychological distress. If you see something bold, it probably indicates, well, it does indicate that by these metrics that statisticians use, we think that this finding is due to more than chance. You know, we call it statistically significant. And science is sort of moving away from these p-value ways of doing things, but we're still with us. So I'm going to share just briefly that when we throw everything but the kitchen sink in a regression model to predict psychological distress in healing pathways participants, these are the adults actually, we find that the culturally specific stressors like boarding school involvement and thoughts of historical loss, those are significant predictors, even once we start to account to more contemporary experiences like what happened to you when you were a kid or adulthood life events that are negative or stressful. Boarding school does sort of wash out of the model in the final model 6 here, but the bottom line is both of these types of stressors matter. And so much so that when they accumulate, these aren't odds ratios, but your chances of meeting a cutoff score to be clinically depressed increased in a almost linear pattern, and then sort of jump off the charts if you've got like 6 or more of these stressors, 7 or more of these stressors, even 5, 4. So again, all of these things accumulate, and if we're not measuring culturally specific, culturally relevant sources of stress and marginalization, we're missing a big part of the story about why these inequities are impacting our communities. Now, this is a path model. So all that is telling you is each of these little boxes is a variable from healing pathways, and it's sort of like walking us through this story to predict an outcome, which is target participant, so the kids, levels of depression and delinquency. And this is an analysis we did. We published a paper on this to show that family relocation experiences, so this is a historically traumatic policy during the 1950s and 60s of relocating families to cities from reservations. There's a whole literature on this, that if a family experienced this historical event and we use it as an anchor to predict grandparent generation alcohol issues, to then predict the next generation's own depression and substance use problems, to then predict how they're parenting and then how the kids turn out. What this is basically a ripple effect of one thing, one relocation policy that we were able to observe significant indirect pathways, so indirect effects, statistically significant across 3 generations. It's asking so much of data to have this one little event, this one variable. It's a little variable, but a huge event, continue to impact the next generation and then the next. So to me, this paper, although it's imperfect, like our measures are imperfect, the fact that anything popped up in this and that it was statistically significant is actually super compelling, and something I think that I'm very proud of, especially because this paper has been picked up to explain why some of the detention policies on the southern border of the United States that remove children or relocate children can be impactful down the line. And so it's having policy implications today. That's a lot of negative. Let's end with positive, okay? So what are some of the things that offset some of these stressors and traumas? We call them coping resources or responses, basically culturally relevant protective factors for mental health. So we've published a number of papers, and again, I'll link up to all the papers at the end of this presentation, showing, for example, that people who are more enculturated, more engaged with their traditional culture, have lower levels of misusing alcohol. That spirituality, Indigenous spirituality, sustains alcohol cessation. So stopping drinking, the strongest predictor of staying stopped drinking is spirituality, and also reduces suicidal ideation and attempts. Positive family relationships, really family, community, culture all go together, are associated with flourishing mental health. And then I'm going to show you something about cultural efficacy. So again, these are sort of general themes, but I'll drill down into just a couple as illustrations for you. So one is, let's think about stress buffering, right? So if feeling that, or perceiving or thinking about these cultural losses, these historical losses is harmful, it hurts my mental health, what can offset that stress? Because that is our story, that is our history, right? So we want to know our accurate history, but how can we buffer that negative impact? Well, culture seems to be the answer in a lot of the models that we build. So in this model, and I won't go into detail here, the effects of historical loss on depression were actually reduced for people who had higher levels of engagement in their cultural ways. So a stress buffering effect. Here's a pathway with mediating effects. So we use this variable enculturation, which again is like sort of a broad indicator of your embeddedness in your traditional, in this case, Anishinaabe culture. And we tried out in wave 9 of Healing Pathways a new measure called cultural efficacy. And we're still kind of trying to decide how to name this, but really it has to do with one's confidence in their ability to learn cultural ways. So in this post-colonial predicament that Dr. Gahn talks about, people who want to access their culture may not be able to precisely because of historical trauma, or may feel angst. Am I doing it the wrong way? Who do I ask? How do I ask? Am I going to be ashamed if I don't know how to sing that song or offer tobacco? These are things that we hear in our own project. So we tried to measure that. And people who feel more confident tend to have lower anxiety and more flourishing mental health. And these are fairly strong coefficients. And enculturation is sort of the root of that. So engagement in culture, actually, the direct pathways didn't show up for flourishing, actually went in the wrong direction. But the mediating pathway through cultural efficacy is what seems to matter. So the lesson here is, how do we measure not just engagement in culture, but the values and the process of enculturation over the life course that changes all the time? How do we get at that in developmentally appropriate ways? This is one of the things that Healing Pathways tries to do. And we're just, I feel like it's just sort of like chipping away at the ice block trying to get there, if only to do one thing, which is to tell the story that communities already know, and that Dr. Gahn writes about all the time, that culture is the pathway to better mental health, but how do we get our empirical measures to adequately tap these ideas? And so, as I mentioned, I would close with two things. One is a cautionary tale, and I'll talk about that now, and then a positive story. So the cautionary tale, this is a paper that that Healing Pathways team members published, where we found basically an interesting story about predicting mental health measures. So in this particular table, we have depression, depressive symptoms, anxiety, and anger being predicted. If you throw spiritual activities into these models, what you find is, oh my gosh, spirituality is positively linked to depression? Why, right? Why is spirituality linked to more anxiety? Why is it linked to more anger? Well, it's very complex, right? So I don't want to go I don't want us to like look at every single one of these models, but if you account for things like discrimination and cultural loss, and you go to the very last block of models, you'll see that those associations drop from significance. So had we stopped with model 1, we might tell the world a story that spirituality is bad for mental health, and that so is not on par with community wisdom, indigenous knowledge, and so not what we would have hypothesized. And in fact, we would have been wrong. You have to also measure the other side of the coin, which is these culturally relevant risks and stressors that I talked about earlier in the talk. The other issue is ethics. Should we be measuring any of this at all? I could go on for another hour about this and about how we grapple with this as a team. Is it the place of science to even get into these spaces? Where our team lands is if we do this through a process of mutual respect, collaboration, sharing, if we do this with broad elder and spiritual leader involvement, if we do this in a good way, as we say in Anishinaabe lands, right, in many Indian country, we hope that this becomes a tool to tell the story through a Western lens that is already known in this other, in our contexts, right? But there's lots of ethical stuff. Again, we can talk about that later. So ending on a good note, I mentioned adverse childhood experiences a few times. What about positive childhood experiences? So some of you have heard of probably this measure of benevolent childhood experiences, or BCEs. I first heard about it at the Native Children's Research Exchange Conference in Colorado. There's some researchers in Colorado who were using this measure and gave us permission to adapt it with Healing Pathways participants. So our team sort of assessed, before the age of 18, did you have a caregiver you felt safe with? Did you have beliefs that gave you comfort? Did you have at least one teacher who cared about you? And the yes is blue, the no is black. So lots of blue on the screen tells you, and I hope that people can see this. Most Healing Pathways participants had all of these things. It was like 70+% had all of these positive or benevolent childhood experiences. And these BCEs, if we look at the red box or where the box is, are predictive of flourishing mental health in adulthood. So these childhood positive experiences are associated with adult flourishing mental health status. Even when you account for adverse childhood experiences, ACEs, which people talk about all the time. Now, the ACEs and the BCEs were significant predictors in this model until we started to account later on for other adult predictors like family satisfaction and emotional support. So bottom line here is BCEs are a more robust predictor of your flourishing mental health than our ACEs, but I don't hear us talking about BCEs all that much, right? So the story here to me is another one about narrative shifting work. So many amazing Native organizations are doing so much, NDN Collective, Illuminatives, all of this work to shift the narrative about Indigenous peoples. As researchers, as a researcher, I have to own that I should also be part of that. And if I don't measure these positive things, I won't tell the story. So in the past, what I want you to know is this is what I would have shown you. Rates of depression in 2 American Indian samples. These are 2 other studies our team is engaged in, which appear to be higher than non-Native comparison studies. But if I actually measure good things, in this case, positive mental health, this thing called flourishing, look at Gathering for Health and Minogijigat, our 2 Indigenous studies, have rates of flourishing that are higher than, or at least on par with, samples of non-Native peoples. But again, am I only telling you the dark story? So this is not to be Pollyanna-ish. This is not to be wiping the issues under the rug. We opened with the health inequities that we observe and live every day, but it is to say, let's measure the whole story. Let's try to. Last message, promise, and then we'll do Q&A, is something that was unanticipated. So in these last 3 years of Healing Pathways, we have asked participants through open-ended questions, self-reported, to write to us and tell us, what has it felt like to be in this study for so long? What do you want us to ask you about in the future? And 99.9% of the comments that they write are shockingly positive, so illuminating. It's very brief, little open-ended, almost qualitative data. So for example, one person said, "This project has made me feel more connected to my reservation and proud to be Native. It made me want to continue my education and bring my knowledge back to my Native community for a healthier way of life." How does a research study do that? Well, it's because of the interviewers. It's because of the community ownership. It is certainly not because of anything those of us working at the university do. And I am humbled when I see that. And also, so much of us hear that research is a negative thing. And I think part of the narrative shifting is it can actually be an unanticipated positive event as well if we take time to look at it. So for more information, you can go to the Healing Pathways webpage on the JHU web pages, so the Center for American Indian Health. You can also email me. And of course, we are going to have time to connect right now on this first day of December. So miigwech, Joe, and I think I'm going to hand it back to you for this next part.
All right, fantastic. What an amazing tour de force of this really impressive and important study. I'm just so glad that you were willing to come and share this with us. And as you already know, our audience is quite broad. I try to advertise these beyond just global health and social medicine and beyond Harvard to try pull in folks from all around Indian country who might have an interest in these issues. So it's another great way to get the messages out around the findings of these studies. Folks, I'm going to ask you if you have a question or a comment, if you wouldn't mind putting it in the Q&A using the function at the bottom of the Zoom screen, and I'll try to pick some of those over the time we have left. While you're
Joe, you got muted.
While you're doing that in the Q&A function, we had an early question from Dr. Dennis Wendt at McGill. Let me just share that with you, Melissa. One thing I really love about your work is that it crosses the US-Canada border. This is a broad question, but I'm wondering if there are any conclusions you have about accounting for these national differences, either in terms of findings, research processes, policies, healthcare access, et cetera. Dr. Wendt says he'd like to see more of this kind of collaborative cross-border work happening.
Great question. Hi, Dennis. Nice to see you typing here. Yes, so when in a lot of these models, you see a variable called remote. What we tend to find is that the 3 most remote reserves that we work with have some differences. And so we account for that often with control variable. We've adjusted standard errors to, long story short though, we know that, for example, up in those remote communities, there tends to be higher levels of enculturation and maybe slightly different levels or types of substance use. In the most recent 3 waves of Healing Pathways, we really tried to tap into policy differences in terms of exactly what you're talking about, healthcare access, coverage, and that's in wave 10, which we have published, I think, 1 paper out of wave 10 at all. And so it's a whole research question that we love collaborators. So if you'd be interested in looking at those data with us, our team has excellent collaborator agreements and the community partners are super excited for people to engage in writing with them.
Thanks, Melissa. And we have several comments and questions coming in about benevolent childhood experiences. For some folks saying, they hadn't heard of this. And new graduate student, Native graduate student Joe DeMeyer writes, "How can I learn more about the modified BCEs you used? I'm working on a research project currently hoping to explore ACEs and PSEs for Native American college students."
Yeah, well, email me as number 1 and I'll send you the measure along with the original source. And she has also given permission for people to, she's published the original source, the BCEs. And we do have a paper under review right now with the data that I presented today. But in the meantime, I'm happy to share it. I would say, the way we assess BCEs is probably just like very minimal. And so I would love to see people expanding this, just like ACE's work has exploded, BCE's work should explode and really broaden in terms of the cultural relevance.
Terrific. Here we have a question. Thanks for your presentation. What accounts for the reasons why certain conditions such as ADHD are, quote, overcalled, unquote?
In a word, racism, I would say. This is what the community team suspected before Healing Pathways started, was that their kids were being labeled in the classroom as problematic, in part because they were brown, and then medicated. And our data, we actually do assess discrimination in the classroom, and there's very high levels of that. And interestingly, my colleague Kelly Sittner published a paper that you can link up to that demonstrates that the pathways to angry and mental health challenges are discrimination leading to anger, not anger leading to discrimination. So people would say in communities, for example, like, oh, well, they're being discriminated against because they're acting out. No, it goes the other way. And that's what the longitudinal data can show us. But if I had to say it in one word, I think it's racism and discrimination.
Helpful. Our colleague here in Global Health and Social Medicine, Byron Good, writes, unbelievable study. Can you remind us of the ethnographic context of the study, a quick reminder of the sample size, and what data do you have on psychotic disorders?
No data on psychotic disorders, access to disorders. It's been an ongoing discussion, and I didn't mention we just got funded to do another round of assessments, including the third generation. So these target participants who are 30 years of age now, their children will now be enrolled in the study. So it's something we will explore again. There's lots of cultural perspectives on those disorders. So, and I won't get deeply into that. In terms of the context of the study, I think you're asking for sample size. At baseline, there were about 746 participants at baseline. Of those, roughly 698 are still living. We've lost some of the community members to early death, which was part of how I opened this talk, and hung on to over 80% of them through 20 years. Did I miss anything, Joe, on that question about something about socio?
More about the kind of ethnographic context, by which I think he just means more about like the background of the study and who all is involved and what, what can we take about the specificity and the generality of this set of 8 reservations and reserves? Yeah.
So what I think is the strength of Healing Pathways is that you've got 8 very distinctive communities, all with a shared cultural base, right? So at least have that shared, not even the same, the language is the same language family, but there's certainly dialectical differences. Certainly some of them border cities or towns, some of them are super remote. And so if you can take all of that together, it's a great way to generalize to other Anishinaabe communities, for example. When we compare our data to other culturally representative samples, so for example, the American Indian Superfip study, which includes multiple reservation communities in the Southwest and the Plains, we don't find huge differences actually in predictors or patterns. We do find a lot of distinctiveness to Indigenous peoples in Oklahoma, which I think is interesting. There's a unique context in Oklahoma. And so the age-old question of specificity versus generalizability, what I would say is the way we approach the research, the patterns, the measures, those things are very generalizable or adaptable to all kinds of contexts. Would I generalize everything we find in Healing Pathways to all Indigenous peoples? No, but I wouldn't do that for any study either. So I think it's, just balancing it.
Yeah, makes good sense. So it appears that there's a little group of folks collectively watching in Harvard College. Here's from an undergraduate viewer. How can Indigenous communities and researchers from the broader Americas, south of Canada and the US, be included in this kind of work?
It's a great question. I think there are some excellent places, including Harvard, and I would give a nod to our colleagues at the Indigenous Wellness Research Institute at the University of Washington that I think build consortiums. And I do think that is one thing that all of us should do. And Joe, we should talk about this more. Really consortium building with Indigenous peoples globally, because the story of colonization and the measures that we use, for example, the historical loss scale, has been adapted for Nepalese. It's been adapted for Taiwan. It's been adapted for use in Australia with Indigenous peoples, Aboriginal peoples. So those types of things I think anybody can use, and we're happy to share, and you can always reach out to me. But in addition to that, consortium building, tapping into existing consortiums and centers like the work that Dr. Gon does, like the work that the University of Washington does, at the Indigenous Wellness Research Institute, all of that matters. And then I would say even professional organizations. So I don't know if you're in mental health, the person who asked the question, but Dr. Gahn is deeply involved in the Society for Indian Psychologists, SIP. So those types of things really help out. And also you can email me anytime.
Wonderful. We have a comment from Dr. Denise Newman, who was an original contributor to the Dunedin longitudinal study. She writes, not a question per se, but I think about the term in a good way and wonder about science's relationship to this. It is clear that your research study has become a cultural tradition for the community of participants. Cultural participation is thus part of flourishing.
Oh my gosh, I love that comment. Can you save it for me, Joe?
Yes, well, so we can send this to you, sure.
There's a book called Research is Ceremony, right? And this is something I'm really, truly on a personal level, I'm grappling with. What our community team recently brought up the idea that we need to sponsor a drum, we need to sponsor an Eagle staff, things that the hairs on the back of my neck go up a little bit because I still worry about the Western influence and does this mess up everything, or should I just lean into that and accept it? And this comment really is hitting that for me. So I appreciate it so much.
Thank you. Here's an interesting question that's both conceptual maybe and methodological. Since more Indigenous people are mixed race and living off of the reservations, how might we measure the impact of cultural loss for their mental health?
Excellent question. And the good news is we can with this new iteration of Healing Pathways. So while Pathways started on or near reservations and reserves, as you might imagine, a good chunk of those original participants now live all over the place. So that's been a tricky part of this longitudinal study, is tracking participants who move all over the world, mostly around the US and mostly to cities like Minneapolis, but also all over the world. So one of the untapped pieces of the Healing Pathways participant stories that our team is working on, and again, welcomes collaborators, is really looking at urban-rural differences as people move off reservations and reserves. Now, with the next generation, as we enroll their kids, who are little ones right now, well, everything from 5 to 18 years of age, to be honest, they may be only growing up in an urban context. And so now we've got this new cohort of descendants who we can answer those types of questions with. And I think it's so important, as most of you on this call probably know, most Native people live in off-reservation contexts, but most Native research seems to be in reservation contexts. Dr. Gahn is an exception to that, but we really need to change that.
And I'm thinking a little bit about this question of internalizing and externalizing disorders in terms of the diagnostic stuff. And there have been findings from multiple studies, epidemiological studies, about the fact that American Indian Indigenous populations might reflect lower rates of the anxiety, the depression, the internalizing disorders. And the question's sort of been, is that a measurement artifact in terms of like how we're asking those questions, or is that substantive and robust? And I'm wondering if you feel like you have a confident answer about whether it's real or artifactual.
Right. I don't have a confident answer, but it's something I've thought about, written about, and one way that we're trying to do better is to really look at qualitative and ethnographic research. So for example, making sure we're also measuring indicators of loneliness, making sure we're also measuring indicators of grief that may tap into this lived experience of distress that a typical PHQ-9 may not. I think when we look at our screener measures, so the non-diagnostic indicators like the PHQ-9 or the CESD, for example, we do see sort of higher levels of internalizing disorders than if we only looked at the diagnostic measures, which tells me the diagnostic measures, there must be some sort of validity issue going on, right? Or it's respondent fatigue. These surveys are so long, but actually, I don't know that it's that, because a variety of things that we've checked. So I don't have the answer to it, Joe, and I do think qualitative research is the answer. And so I will say that in the new iteration of Healing Pathways that I keep mentioning just got funded, we did write in a qualitative arm to the study that we had not done before. So we'll do intergenerational interviews around all of these topics to try to get at this nuance.
Fascinating. Dr. Doug Whalen from Yale writes more of a comment. Your focus on the protective factors resonates with my view of epigenetics. While many of the studies focus on inherited trauma, I think the resilience is just as likely to be epigenetic and maybe more important. You have any thoughts about the place and role of epigenetics in any of this?
Absolutely, yeah. We've actually been approached by epigenetic scientists who don't do work in Native context at all, because the phenotypic profile that we have of the participants in healing pathways is probably unparalleled. And so if you coupled that with epigenetic research, you might have something powerful. I think our team just isn't quite there yet, right? So that wouldn't require biological samples and a lot of things. I'm not saying it's off the table. And certainly if you gave it the strengths-based spin that you're talking about, that feels more comfortable, I think, than, oh, tell me another story about my inherited trauma. So I think we're open to those conversations. I feel like the little I know about epigenetic inheritance is the science is so new for humans. There's so much in animals and other things, but I do feel like this is what elders and healers talk about, right? Like, I ancestrally remember, I have a genetic memory. So we use these words in community context. We just don't have the Western science caught up to that yet, probably.
Great. And here's a question from the Dene nursing researcher, Dr. Michelle Kahn-John, who I think will soon be your colleague at Hopkins. Thank you. Would you share pearls of wisdom or best practices approaches about engaging with youth adolescents?
Yes, Michelle, welcome to Hopkins soon, and can't wait to get to work with you. Engaging with youth, yes. It's all about the community team. It's all about having young people on your team. So in the YouTube little clip I shared, Devin, for example, who is the last speaker, he's a young guy too. Like he knows how to talk to people. So I think it's all about community wisdom on these things and knowing what adolescents want to do. Keeping in mind that these interviewers now, honestly, we've hung on to almost all of the interviewers from Healing Pathways. So the same interviewer has been going to visit these kids who are now young adults over 20 years. As someone mentioned in the comments, there's a relationship here. There's a trust here. There's a professionalism there on top of all of the connection. So it's this relational thing, but also a professional thing. And the other thing is not shorting kids in terms of not underestimating the power of kids to understand that they can contribute. So some of the comments I showed on one of the last slides, that if you really engage participants to understand the purpose of a study and what the bigger picture is, they're more willing to participate and they're more willing to engage and they're more willing to be truthful. And there's actually science to back that up. And we use that science to really tell the story of pathways. And that's why the YouTube channels and all of these other things matter. And the other thing is, now we've started working with like young undergrads and medical students a bit. And this past summer, they created like TikTok videos and things I don't know how to do. But, you got to have kids to reach the kids, I think.
Amazing. Do you have data on socioeconomic factors? I'm curious, for example, about if your work squares with Braveheart et al.'s EPI study using the NESARC, which showed that Indigenous mental health and substance use disorder disparities between the general US population nearly vanish when controlling for income, education, et cetera.
Yes, we have a huge amount of data with regards to socioeconomic conditions, influence, et cetera. It's a weird thing. I think that question was from Dennis. It's a weird thing, Dennis, because if you use like conventional indicators like income, we find almost nothing. And I think it's because there's not a lot of variation to predict. But if we use measures like financial strain, like this, these are survey measures, like how hard is it for you to pay your bills? Have you had to skip meals in order to get by? Did you have a time when you couldn't make ends meet? Those seem to tap into the financial stress better. But then we have the context of living on a reservation, which is very different, I think. And we've sort of played with this and we can't get a story to pop out. Maybe it's because of our measures, but we don't see the protective influence of income on the res in this sample that you might expect. And I think it has to do with maybe concentrated disadvantage or relative advantage. And what does that mean in a context where your family is relying on you maybe to contribute? There's all sorts of cultural nuance to this, but I will say that the story is not clear in healing pathways like it was in the NESARC data, not at all.
Very interesting.
Mhm.
I'm wondering if you can assess a bit the healing pathways study that you've been involved with and leading now in terms of its longitudinal tracking of youth and stressors, as well as enhancers of thriving and flourishing relative to other longitudinal data we have on Native youth. You mentioned some comparable findings and outcomes from other studies, but can you say more about what those studies do and don't do relative to what you're able to do through healing pathways?
Yeah. You know, I think the difference is, well, number one, the span, right? So having Pathways has multiple generations, now 3 generations we will have. I don't know that anybody else anywhere has that. And if it's out there, I would love to collaborate and share, because I think we could learn a lot if we shared measures, for example, or processes. We certainly borrow from all the studies that came before us, the Great Smoky Mountain studies, the AI SuperFIP, there's a bunch of studies out of the University of Colorado, the existing national studies. But I think ours is different also in terms of cultural specificity. We have a culturally specific group. We also really pay a lot of attention to innovating on measures, as I've been trying to talk about. And I think that's distinctive, although a lot of great studies in Alaska are doing this. So what I would say is we are so grateful to build on all of these other studies. And then there's this special unique thing about this intergenerational influence that Pathways can also share with those to come in the future. But you know, it would take 20 years for us to get to a replication in another context, right? Like that's how long it's been. And so my goal is, as I keep saying, we welcome collaborators. We need to get this data out there in a good way and in a collaborative way with community partners, so that it doesn't just sit in our computers or on a shelf or on the tribal computers. It's actually being used and we can build on each other. So anyway, I don't know if I'm directly answering your question, Joe, but I think this specific uniqueness is intergenerational data.
Right. And in that respect, you also mentioned, the fact that you interviewed parents for so much of their information, or caregivers at different points. Can you speak to maybe what are some of the most compelling findings between parent outcomes and offspring outcomes? You talked, of course, about benevolent childhood experiences, which may or may not be apparent. So I'm just wondering what you found with specific association between parents and their own offspring.
Yeah, well, a lot of it is what you would expect and what you find in a lot of studies, which is sort of like I showed you that path model. If a parent is struggling, they tend not to be the most ideal in their parenting behaviors, and then the kid has higher risk for bad outcomes. On the flip side, if a parent is doing well, a kid tends to do well. That story's been told so many times, and actually our funder, NIDA, has said, we don't even care about that story anymore. We know that that's the story. And so what we're starting to look at now is even like cohort differences across generations in substance use. So these are very preliminary findings that our collaborator Dane Houdala just ran. But what we're trying to assess is like distinctive patterns of drinking alcohol, for example. So like the old adage, not that old, but is when American Indian people drink, it tends to be in a sporadic binge nature, but there's a lot of abstinence. Well, in the most recent cohort, we're finding what appears to be more social drinking, as the dominant culture would call it, right? So people who have a drink now and then, and that's it. They're not abusing per se, and they're also not abstaining. We have to drill deeper into that, but that's one of the goals, one of the aims for the new study is to really look across these 3 generations. Are there distinctive profiles? Is there something generationally happening? Maybe it's sort of like the, the Americanization of indigenous substance use or something, something like that seems to be happening, but it may also be breaking down stereotypes and not internalizing them anymore, and just rejecting those and doing you do you, as the kids say, right? So to me, Joe, that's what's really compelling, is these generational differences.
That's just incredible. Wow. So excited to see what comes from that. This was obviously a deeply participatory process with, the community advisory boards, although you called them something different, as I recall. But what are some of the ways that the participatory approach shaped this project, or what are some of the biggest, decision points, or selection of measures, or refining of questions? How is it that this was shaped by that participatory ethos?
Yeah, every step of the way. It's slow going. There's 8 communities. Now, I cannot understate how complex that can feel and get, because you can imagine you have 8 teams meeting individually, then we all come together. Do you think that each of the 8 teams has the exact same idea about how to ask questions about missing and murdered Indigenous women, for example? Of course not. We're people. We're just, we have different. So it is a very iterative process for everything. What I will say, as I mentioned before anybody even steps foot into interviewing or even applying for a grant, first and foremost is getting tribal government support for the project and for our processes and protocols, then applying for money, then going through all these processes. I was mentored by this team through graduate school. I was so fortunate to be recruited to the University of Nebraska to work with the original PI, who was Les Whitbeck, and he listened to the community team, who said, much respect to you, Les, but we need a Native person running this project. And then they invested in me, they mentored me, and they've allowed me now to serve as the PI. And so everything from that story, and that's a whole story about how I even got recruited at my grandmother's kitchen table over chili. It was very bizarre. I didn't know what was going on, to how many hours and meetings and monies it takes to build one survey, even a scale. And every single question is reviewed by all members of the entire team and piloted and checked, and somehow we make it work. But the longevity, I got to be there in the beginning stages as a student, and it's been a transition, but it's a wonderful team. It's all because of the team. Right.
Well, we're so grateful that you were inspired at your grandmother's table to do such important work. We need to start to wind down here. Here's one other question. People are really taken. I'd say there are a number of questions about ACEs and BCE stuff, as we talked about already. But one person writes, it makes sense that should a person have a significant ACE score, they could also have a significant BCE score if raised in a multi-generational family system, like love of a grandparent or having a good experience with a caring teacher. When you assess these, typically, of course, they don't ask, the context, like even the caregiver or anything like that. Do you have any insight from any of your other measures about, whether parental, grandparental, that sort of thing?
Oh gosh, that would be a fun next paper. Yes. So we know so much about the family and household structures of these initial years. So those adolescent years, we ask questions like, who was involved in raising them, who lives in the home. For every parenting measure, we ask who is involved in this. And we also ask the current generation of parents, who is involved in raising your kids. And it turns out that grandmas and aunties and uncles and siblings are much more involved than even the other parent, right? And so we have not overlaid, done a cross tabulation of BCEs, ACEs, and household structure, or not even household, but just parenting influence and parenting beyond the nuclear family that people talk about. But we could, and that's a really cool idea.
Yeah, it is.
Mm-hmm.
One final comment here, rural versus urban. That's another interesting contrast. People have lost their land, and in particular, speaking to the context of the Amazon, people who've lost their land or simply migrated, retain extended family ties so they or their children can spend extended periods of time deep in the Amazon. And conversely, those living in the deeper Amazon can stay with family in urban sites for many different reasons: school, some traction with government officials, specialized medical care, learn a trade, among others. Hence, a clear break between urban and rural is not often seen. And I wonder if you want to speak to that a little bit. Obviously, you've been following these people for 20 years, and you probably watched different migration patterns happen. So what insight do you have about that urban, rural, and movement there?
Yeah, we're only starting to tap it now, because from waves 1 to 8, the kids mostly stayed pretty close to the reservations, honestly. But from wave 8 to 9, we had this 7-8 year gap, and a lot of them moved off res. And then from 9 to 10 and 10 to 11, we also assess, are you on or off, on or off? We have not tracked that, like we haven't ran those data, but we have those data. So the migration cycles that this person is talking about were on our mind and why we assessed it in the first place. And I totally agree, this whole context stuff, we just need a whole bunch of descriptive papers, even like what percentage of people are moving. And again, the data are so rich, and it's all because of the team. They collect so much information. So thank you for the paper ideas.
Well, that's just excellent. And again, Dr. Walls, I want to thank you for contributing your time and expertise in this amazing presentation at this instantiation of our Indigenous Health and Wellbeing Colloquium series. For the broader audience, we're trying to do, some of these every year, a couple of semesters. So we will be having another one, but not until the new year. On February 9th, in fact, if you're hearing this, you might want to reserve this same time for another virtual seminar featuring Dr. Dave Wilson, who's the director of the National Institutes of Health Tribal Health Research Office. And he'll talk to us a lot about policy and some of the projects and consultation that the NIH does with Indigenous stakeholders. But before then, the departmental seminar continues on, and next week we're featuring a symposium on climate justice and degrowth. This time, next Wednesday, introduction by our chair, Dr. Paul Farmer, speakers, Dr. Maxine Berkset and Dr. Jason Hickel, moderated by our colleague, Dr. Eugene Richardson. So we hope to see you there next week, and of course in February for the next Indigenous Health and Wellbeing seminar as well. Thank you again all for attending, and Dr. Wells, can't thank you enough. Walls, I so appreciate your coming. Thanks so much.
Yeah, I'll talk to you again soon. Thanks so much.
Right.
Appreciate
Bye-bye.
it.